Hello and welcome to the Genetics Podcast. I'm your host, Patrick Short. My background is in population genomics and studying the genetic causes of rare disease. I did my PhD at the Sanger Institute in the University of Cambridge and have been in biotech since 2018 when I started Sonogenetics. Sonogenetics helps academic and industry researchers to run large-scale genetic testing programs that speed up their clinical trials, generate data sets for the next big breakthrough, and give participants the best possible experience taking part in research. Each episode of the Genetics Podcast, we bring you insights from the leading minds in genetics and precision medicine, including household names and Nobel Prize winners, as well as early career scientists and biotechs working on the next big breakthrough. Whether you are a scientist, entrepreneur, executive, patient advocate, or simply someone curious about how genetics shapes our world, you're in the right place. Thank you for listening, and let's get started. Welcome everyone back to the Genetics Podcast. I'm excited to be here with Dr. Versha Pleasant, who's clinical assistant professor in the Department of Obstetrics and Gynecology at the University of Michigan, and she's also the director of the Cancer Genetics and Breast Health Clinic at the Voigtlander Women's Hospital. Versha's work has focused on health disparities, particularly on breast cancer and genetic testing barriers facing Black women. She's a co-investigator on a T32 NIH grant that's focused on ways to increase access to education, genetic testing, and genetic counseling among African-American women. And prior to career in medicine, she actually worked for several years as a program manager in sub-Saharan Africa. So needless to say, you've got a lot of experience on the ground, working closely with patients in lots of different environments, and now taking that experience into your research career to try to advocate for better access to genetics and other kinds of health technologies. So thank you so much for joining us today. I'm looking forward to the discussion.
Thank you so much, Dr. Short, for having me. I am so excited to be here today. And I firstly just want to acknowledge that you have had some leaders in the field of genetics on this show. And I love the fact that you are interested in interviewing someone like me who is not doing traditional research, but working directly with patients with pathogenic variants in these cancer susceptibility genes. I think it's a testament to the breadth of this podcast, showing that you all are interested in not only the technical aspects, but the human aspects of genetics. And I think that's really great. So thank you for having me.
Thank you for saying that. It's amazing work that you do. And I love to have the variety of guests because you can only talk about genome-wide association studies for so long before you start to ask the question of how do we get people in these studies in the first place, and why are they all so damn biased, and how do we fix that problem? So I'm glad that there are people like you that are actually working upstream of this problem. You've shared in one of your papers that Black women actually have a 40% higher mortality risk from breast cancer than white women, which I had to read 3 times before I fully understood the magnitude of that. You don't see statistics quite that high very often in medicine. And I think there's also more than 70% more likely to experience delays in treatment, which of course can cascade into some of these poor outcomes. I'd love to just talk a little bit about what the biggest drivers are behind these disparities from your perspective, and then of course some of the things that you are working on, with collaborators to try to address those disparities.
Absolutely. Those disparities are alarming and unacceptable. As with many things in medicine, there's usually not just one reason. Imagine a big gymnasium or auditorium with a huge panel of light switches. And Dr. Short, you flick on one of the light switches and some of the lights come on, and then you flick on another and more lights come on, and you keep going down the line until you flicked on all of the light switches, and then finally the entire room is illuminated. This is a metaphor that I frequently use to explain cancer, and this also applies to health disparities, right? It's usually not just one thing, it's a culmination of different factors. But if I had to choose kind of the 3 biggest drivers that for why we're seeing this increased mortality among Black women regarding breast cancer, number one, they are more likely to have more aggressive breast cancer subtypes. So particularly triple negative breast cancer, right? Breast cancer that's negative for hormone receptors, negative for HER2 receptors. It's a cancer that's harder to treat. We see it in 10% of breast cancer subtypes in the United States. Black women are 2 to 3 times more likely to have a triple negative breast cancer. They're more likely to experience higher recurrence rates, more likely to be diagnosed at advanced stages, right? So that's one piece of the puzzle. Number 2, as you mentioned, they also are more likely to experience delays in care, with some of the data suggesting 60 days from time to diagnosis to the start of treatment, some data even suggesting up to 90 days between diagnosis and treatment. That is a huge problem. And then, third, we can't talk about racial health disparities without talking about social determinants of health, right? So things like access to medical treatments, health insurance coverage, transportation, housing, and then the role that systemic racism plays in all of that. We really cannot ever talk about health disparities without addressing those things. But in the same way that these challenges are multifaceted, there are opportunities for change, and those changes also must be multifaceted. I like to approach it from like a three-layered approach where we start from the ground up. Let's talk first about patient level approaches. We have to get the community engaged. There has to be more education among the community about how prevalent breast cancer is and how it disproportionately impacts Black women. Breast cancer is the most commonly diagnosed cancer among women in the United States. 1 in 8 will be diagnosed with breast cancer in their lifetime. 1 in 8. If you think about a loved one, a colleague, a coworker, that is a really high statistic. So we have to continue to increase awareness about breast cancer. Next, we have to approach it from a health systems level. Right? How do we increase access? How do we make sure people have health insurance coverage? How do we ensure that people have access to mammography, which is a great screening tool for breast cancer? And how do we increase access to genetic counseling and testing? And then we also want to look at things on a policy level. That's the third point. And that's sort of the overarching, how do we create policy that then trickles down to people and their day-to-day ability to access healthcare? And I think this is really where genetic counseling and testing can play a huge role. Prevention, early detection, for instance, my big question is, how do we integrate genetic counseling and testing into pre-existing preventive healthcare services? That's what we should be doing. Because if we're saying that genetic counseling and testing is the cornerstone and the forefront of precision medicine, we can use it, we can leverage it to make people live healthier lives. Genetic counseling and testing is key to helping people assess their risk, identifying people that are increased risk before they ever get a cancer, and linking people to preventive care. Those are the ways that we can address it.
When you think about the early screening paradigm, you've obviously got genetic testing, you've got mammography, you've got other tools. When we think about the Black community in particular, how do you think about the right way to structure that in order to balance? Obviously, you don't want to overscreen and need to think about cost benefit analysis, but it's clear right now that there's work to be done on both fronts, and you need more access to mammography, but also more access to genetic testing, particularly, I guess, in cases where there's a known family history, right, where there's a huge access gap today.
Absolutely. That's absolutely right, right? We have to strike a balance. We don't want to overscreen and overtreat people, but at the same time, the data that we have, especially on Black communities, shows that there are barriers to access for care and treatment for breast cancer. And it shows that there is a low uptake of genetic counseling and testing among this community. So we're kind of behind the 8 ball, and we have to find
Yeah.
ways to catch up.
You used a term in the paper which was new to me, but I thought was a really good and important concept of racial health duplicity, which is you'll correct me if I mess up the definition at all, but essentially where Black people are intentionally included in studies that may harm them. And before anyone thinks that this doesn't happen anymore, it definitely does, and it clearly happened historically in major cases. And then on the flip side, you have exclusion from studies or health, access to testing in a health system that may actually benefit them. So it's this double-edged sword. And obviously we want the reverse to happen. We want to protect people from studies that don't have their best interests. We want to make sure that access is as wide as possible to the studies that are helpful to them and helpful to their community. How do you think about breaking down this problem? Because there's trust somewhere at the core of this, right? To solve the issues that we have, we need to find ways to help people get more involved in the research that is beneficial. But simply saying that you're going to do that doesn't make it happen, right? There needs to be practical on the ground efforts.
Absolutely. So racial health duplicity is a term to explain the dichotomy between these two seemingly different phenomena that have similar outcomes. And that involves the sort of over-inclusion of Black communities in a lot of this potentially harmful research. But then on the flip side of that, the under-inclusion of Black communities in research and medical science. And this all stemmed from my interest in variants of unknown significance in VUS. And we know that there's a greater likelihood of VUS among people of non-European ancestry, right? And some people, there's a lot of reasons for that, but some may attribute that to the underrepresentation of people of non-European ancestry in genome-wide association studies, right? And so, interestingly, there is this created by the British Academy and the University of Oxford. There is a GWAS diversity monitor. So this is like a real-time monitor looking at the culmination of data regarding ancestry and GWAS. And basically, it's saying that 94.5% of all GWAS consist of people of European ancestry, right? And that's problematic because that does not create for a diverse population for which to study genetic differences. And, there are initiatives going on right now, which are great. H3 Africa, the African Genome Variation Project, all of us, the Thousands Genome Project. But we really have to do more to diversify things. The problem with this is that when we go to use precision medicine to stratify risk, it doesn't work as well, right? So you end up with these equivocal, non-actionable results that we just monitor over time. A person that has a BRCA1 pathogenic variant, for instance, that I'm counseling, I'm offering them mammogram, annual breast MRI, risk reducing mastectomy as an option. I'm offering them surgical removal of tubes and ovaries, risk reducing BSO, bilateral salpingo oophorectomy, to reduce the risk of dying from ovarian cancer, pancreatic screening, melanoma screening. A person, however, with a BRCA1 VUS, they're not offered any of those things, right?
Yeah.
So if we take a step back, though, let's look at kind of how history has trended in the United States. History, unfortunately, America has a very tortured history of the medical mistreatment and harmful involvement of Black communities in medical research, right? Tuskegee syphilis study is a great example of this. That was a 40-year study looking at the effects of untreated syphilis among the Black community, even when penicillin was made available, which is the treatment for syphilis, right? We have J. Marion Sims, called the father of modern gynecology, who performed numerous unanesthetized and often public surgeries on 3 Black enslaved women, Lucy, Betsy, and Anarcha, in order to perfect the repair of the vesicovaginal fistula, which is a complication from childbirth. We have Henrietta Lacks, who is a Black woman who sought treatment at Johns Hopkins University in the 50s for cervical cancer, and without her awareness or consent, had her cells taken and used in scientific research. We all benefit from HeLa cells to this day. They were used from everything from vaccines to space research. We have the Virginia Eugenical Sterilization Act, which took place in the 1927 to 1979. And this was an act in which thousands of people underwent forced sterilization because they were deemed unfit to procreate based on race, ethnicity, ability, socioeconomic status, many of whom were African American, some of whom are still alive today, right? And so the commonality in all of these events is that these were all research, medical interventions in which Black communities did not receive any direct medical benefit, and in fact may have been harmed by these studies, were harmed by these studies. So medical history has kind of trended in one of two ways, right? We have the harmful inclusion of Black communities and then harmful exclusion of Black communities. Both extremes cause harm, and both of them conflict with the pillars of medicine. The exclusion of people of non-European ancestry and GWAS, this is an example of racial health duplicity because it has downstream long-term effects on the way that we identify and treat and prevent breast cancer.
When you think about how to solve for that in 2025 and beyond, what does it look like? I'm thinking, for example, we have major clinical trials that are ongoing in diseases like APOL1 kidney disease that we've talked about here that are much more prevalent in people of African ancestry living in the United States. We've got examples that you talk about like triple negative breast cancer, where it's significantly more impactful in this community. If you're advising someone who's designing a genetic study or a clinical trial that's focused on trying to help this community, what's the best way to start to make sure that you're on the right side of this equation, not the wrong side?
Right. This is a great question. And I think this is one that it's an ongoing question. We have to constantly be asking ourselves when we engage in research. It's important to make sure that any research or interventions that we're doing is inclusive of people that have been potentially historically excluded from research. But we also have to do this in a way that is mindful, in a way that's culturally appropriate, in a way that we're engaging community members and we're building trust. This is really, really important. Oftentimes, the research teams will sort of come in, gather the data that they need, leave the community, and we have to think about this community for which we are asking for data. Is that data coming back around and helping that same community, right? We have to also make sure that people receive fully informed consent. We have to make sure that research participants really understand the breadth of the research, and they understand the potential benefits to them and people that look like them. I think that's really, really important.
Yeah, absolutely. I hopefully anybody's listening who's in that boat will take the advice to heart. I was curious to hear more about the paper that you published recently, where you laid out a vision and a proposal really to consider universal genetic counseling and testing for Black women, with a focus on breast cancer in particular. But I think it could be considered for cancers more broadly, and other kinds of genetic testing. It would be great to talk through people who haven't had a chance to read the paper, and we'll link to it in the show notes so people can get access to it. What do you have in mind there? What's the rationale behind considering universal genetic screening, and why now, and how might we go about starting this so this is something that can gather momentum?
Yeah. Universal genetic testing in the Black community really has the potential to mitigate some of the racial health disparities. And again, we talked about how there's a lot of potential reasons for the increased mortality. There's a number of solutions. And again, if we're talking about precision medicine, genetic testing is at the heart of that. And we have to find ways to scale up our efforts to reach Black communities. Much of my work is focused on community outreach and patient education, and how to integrate genetic counseling and testing into systems level approaches. But this paper really talks about genetic counseling and testing at a policy level. How do we go a little bit higher and create a trickle down effect? The reality is that most health insurance companies will cover genetic counseling and testing if a patient meets NCCN criteria. So as we all know, the National Comprehensive Cancer Network sets out the hereditary breast and ovarian cancer screening guidelines for the country. And these are typically the guidelines by which we abide to decide if a patient should get a referral to see a genetic counselor. And some of those criteria include things like a personal history of breast cancer at 50 years or younger. That's considered an early onset breast cancer, multiple breast cancers in the family, triple negative breast cancer at any age, a personal or family history of ovarian cancer, pancreatic cancer. There's some parameters regarding prostate cancer, right? So data showed that Black women are more likely, as we said, to be diagnosed with a triple negative breast cancer, which is one of the NCCN criteria. The data also show that Black women are more likely to be diagnosed with early onset breast cancer, another NCCN criteria, right? So my question is, if Black women are more likely to meet two of the criteria, major criteria, the already established criteria, and they're more likely to die from breast cancer, which is generally a very treatable disease, then why not offer universal genetic counseling and testing to those groups, right? If the goal of these criteria is to identify people at high risk, why not include those that demonstrate the highest risk? So this article is called Universal Genetic Counseling and Testing for Black Women, a Risk Stratify Approach to Addressing Breast Cancer Disparities. I published it with my mentor, Dr. Sophia Mariver. And in this paper, we're really examining the feasibility of offering universal testing to Black women. And it's also talking about addressing the barriers. And I know the first one, the elephant in the room, obviously is race. And, race is a social construct that has no scientific basis. And really, in genetics, we prefer to use the term ancestry when we're talking about population descriptors. And so we address this in the article. We recognize that, but we also know that knowledge of ancestry for some groups is a privilege, right? So if you talk about Black Americans and people that trace their ancestry back several generations in the United States, some cannot trace their ancestry prior to the transatlantic slave trade, right? Another thing is we have to acknowledge the intersection potentially of race, ethnicity, and ancestry. If we look at the data of triple negative breast cancer, We see a high rate among Black Americans, and we also, in the continent of Africa, we see a high rate in West Africa compared to, say, East Africa. And this, again, creates a very clear ancestral link, because we know that people were displaced due to the transatlantic slave trade from West Africa, largely to the United States. We also talk about other challenges, right? Things like medical mistrust. We talk about cost. We talk about access to testing, discovery of more VUS. All of these are challenges, but we have opportunities to address them. We have the opportunity to do greater education and trust building among the community. We talked about this before, about how do we get out in the community and really share with people that how genetic testing can benefit them. I think there's really a need for more education of healthcare providers on how to discuss genetic testing with people. Hiring more genetic counselors from minoritized backgrounds is really important. And when we talk about equity and representation in the workforce. And then when we talk about VUS, yes, that is a challenge, but at the same time, it's an opportunity, because the more we test, the more we gain information about VUS. We learn about things like private variants. So this idea is definitely controversial. I recognize that, but it's also revolutionary. And I think it could really increase access to genetic counseling and testing. It could identify Black women who are at high risk for aggressive cancers. And it could also open the door for cascade testing, where we're learning more about risk among families. Black women, the bottom line, Dr. Short, is that Black women are dying uncommonly from a very common disease. This is a problem. This is a problem. And this paper is really a call to action from the medical community. How can we improve the care of this community?
How do you imagine something like this getting funded? Is this something that could be funded at a federal level, or is this, are there roles that diagnostics companies can play? I'm curious for how you're thinking about putting this into bringing this to life.
I think all of those are possibilities. I think if we get buy-in from genetic testing companies, as well as federal subsidies, grants, research, I think there are a lot of opportunities here. And while I recognize that cost could be an issue for anything that's considered universal, we also have to recognize that there's a cost to missed opportunities in this
Yeah.
community. There's a cost to breast cancer mortality. So yeah, I think it's going to require buy-in from various levels, from health systems levels, and again from a policy level. And I definitely think that the NCCN, it's worth taking a look at the criteria again.
Yeah, I mean, just taking a step back on some of the big genomics initiatives in the last decade or so, and even in the last couple of years, we're seeing obviously a lot of money being put towards population initiatives like All of Us in the US, Our Future Health in the UK, and similar type programs. I think All of Us has definitely made efforts to try to reach a broad population, but just given the percentages of people in the United States who are, who come from European ancestry or African ancestry, you're never going to get to the scale of people of African ancestry if you follow the percentages, right? So something like this makes sense from that perspective, to just say, look, why, if we acknowledge there's a problem of access to diverse and representative data sets, then why don't we just sequence everybody? It also makes me think about newborn screening programs, right? There's a lot of money going into those programs for good reason. I think they're gonna be really transformative, and it's worth thinking about something like this alongside those type of initiatives as a little bit of a national or international scale moonshot, because the points that you made are really clear, right? There's a lot to be gained immediately from a health system perspective, but then you have a nice figure in the paper that also talks about the research impacts that you have. You're going to pick up more new variants for per dollar spent, right, than any other effort that you could do, because of the level of genetic diversity in the African ancestry compared to others, right? So there's a lot of benefits that I see here of considering something like this.
Absolutely. And another thing that I just want to add, Dr. Short, this all has to be coupled with community education, community engagement, community education, and trust building. Again, I make it very clear in the paper that our goal is not to say that everyone should line up and get tested. The goal is to say it should be offered. And when we offer genetic counseling and testing, it is just that. It is coupled with thorough counseling, making sure people really understand the benefit that genetic counseling and testing could have for them and for their families and for their communities. and finding ways to engage people. Not everyone gets their health information from the four walls of a hospital, right? Some people are getting their health information from churches, from social groups, fraternities and sororities. So these are all important venues that for which we can create synergies to really educate people and impress upon people how genetic testing can help them.
Yeah, absolutely. There's a point that you had me thinking about as well when you're talking about the NCCN criteria, which shows up not just in this case, but broadly across genetic testing and genetic medicine in lots of different cases, which is this requirement or consideration of having family members who've had testing and had a confirmed variant. It seems like the kind of thing that makes sense on paper, but then when you start to look at the social determinants or other historical factors, it starts to break down a little bit because the people whose parents had genetic testing 10 years ago or 20 years ago or whatever it been would have had a level of access to testing that's very different. Even if we think that there is disparities today, then there are certainly more significant and major disparities 20 years ago. So you start to introduce these biases by requiring that there's a confirmed variant for, which is done with the good intent, right? You want to try to limit the number of VUSs or limit the number of false positives, but it has an impact that can be a little bit subtle, which is, okay, my family didn't have access to genetic testing 10 years ago because our doctor, we didn't have insurance, or our doctor didn't have wasn't part of the special projects that enabled them to get testing at that time. And so then a generation later you're cut out, and that sort of thing can be really pernicious and result in people not getting testing today because their family didn't have testing a generation ago.
That is exactly correct. That is exactly correct. I want people to understand the potential generational impact. You use that word, and we're talking about generations that are impacted by cancer and disease, not just by the morbidity and mortality of that particular person when we've missed an opportunity to identify risk early before a cancer happens, but then it has a trickle down effect, right? That then, this person is passing along a pathogenic variant that for which each child has a 50-50 chance of getting it. And then that child has a 50-50 chance. There's a way we can stop this. We can interrupt this legacy of disease. And I think it's really, really important for us to act now with the tools that we have now. We can really make a difference through genetic counseling and testing.
Yeah, I really enjoy this conversation. You've given me a lot to think about. Do you have a sense of what you're focused on next beyond this? You've got other work that's going on, other kinds of things that you're thinking about. What are the big topics on your mind?
Yeah, I want to talk definitely a little bit about some of the research that I'm doing now, and namely a study that I'm doing called Genetic Risk Assessment with Mobile Mammography, or the GRAM study. And essentially, this is taking a look at the premise of the study is that we know that genetic testing is a really powerful tool in identifying people at risk, but it's underutilized by Black communities. And why is that? There's some data suggesting that there is medical mistrust among the Black community, some of which is true. There's concerns about genetic discrimination, also potentially true. But that's not the whole story. There's some data also showing that there is a low uptake of genetic counseling and testing because Black people may not be offered the services by their healthcare providers compared to their white counterparts, even for people that may meet criteria for genetic counseling and testing. And so, the reality is a lot of people rely on, say, their primary care physician to sit down with them, talk through their family cancer history, and provide that referral. My question, though, is what would happen if the responsibility of cancer risk assessment did not fall on the shoulders of the PCP, right? Among all of the many other things that they're doing in their field of work. What if risk assessment and genetics was integrated into preventive care? And what would this do in terms of access to genetics? What if the Black community, along with receiving increased access to genetics, what if that were also coupled with community education, more enhanced education about addressing the medical mistrust and addressing the genetic discrimination? So essentially, we're piloting a project that is taking place at a health center that serves a predominantly Black community, although the study is open to patients of all racial and ethnic backgrounds. And essentially, when they present for screening mammogram at a time when they're already thinking about breast cancer risk, we offer them risk assessments. So we sit down with them and we say, hey, would you like to talk about your family cancer history? We have a software tool that links directly to the NCCN criteria. We enter their personal and family health information, and it'll immediately, once they're done, it'll immediately tell us if they meet criteria to meet with a genetic counselor or not. And if they meet criteria, we provide them with a referral. Even if they don't meet criteria, we still offer the referral because the reality is anyone can get genetic testing if they want to. And so, but anyway, this study is already showing incredible success. About half of our study cohort has met criteria to meet with a genetic counselor. About half.
Wow.
This is wild. And this
Yeah.
shows a sort of missed opportunity, right? These are people that had not previously discussed their family cancer history with someone where their risk was not assessed. Almost all participants have expressed that they really enjoy this service. And, concurrently, and so what we do is we also follow them over time, Dr. Short. So we provide them with the referral, and then we follow them over time to see how many of those people follow through with the genetics appointment, how many follow through with the genetic testing, and then how many receive the results and what the results were, right? So we're also doing community-based education. So this is not just we're going into this community and just dropping off this service. We recognize the importance of building trust and of educating people on the importance of knowledge of family cancer history. So we've done over 15 events in the community. We've gone to churches, we've gone to community centers, health fairs, Black sorority events. And again, it's not just about education, it's about building trust. People want to see us and we want to see them. It's important for them to see our faces and to see that we care about them and we care about their health. And we also get to see directly who this research impacts. So I'm really excited about this study because if the study, is successful, which it is already showing success, my goal is to scale it up. I mean, why shouldn't all women be offered risk assessment at the time of screening mammography? That's when we should be doing it, right?
Yeah.
And then that goes up to kind of the policy level. How do we create policies and set systems in place where women are automatically, right? They're automatically getting their risk assessed. We're automatically screening them to see if they should meet with a genetic counselor at a time when they're getting breast cancer screening. This is the way that this is what I envision moving forward for the way we can integrate genetics into preventive care.
Yeah, that's amazing. Congratulations on all the great progress. When do you expect to have the first tranche of data from that? And not to put you on the spot, science takes time, but I'm just curious.
Hopefully within this next year, we'll see.
Exciting.
But yeah, I
Great.
will keep you posted for sure.
It is
Hopefully within the next year or so.
particularly hard to predict when it's involves the real world and going out with buses or vans or whatever it is that you need to do to pull this off.
Absolutely. Absolutely. But we will definitely keep you posted on those results. And
Cool.
again, my goal is that if this is successful, we scale it up.
Yeah, I think I'm really excited about these kind of things in general because especially as the need for screening becomes so significant, we hear from doctors that they don't have enough time with patients. The level of complexity of what they need to cover is expanding. And I think there's a lot of space for community-based events, especially when you can leverage trust that might already exist or potentially be stronger with a community compared to a PCP or something, right? We have to acknowledge that some people have very strong trusting relationships with their doctors, but not everybody does, and they may not be the best place to get this kind of information or education. So having a more flexible and, dare I say, creative way of getting out in front of people and spreading the message is worth considering.
Absolutely. Absolutely. You brought up a good point. Some people do have good relationships with their primary care physicians, but again, people get their health information from different venues. And I think delivering health information might be more effective in environments where people feel safe, in environments where people feel heard. And sometimes that's not always the doctor's office or the hospital, right?
Yeah.
So we have to recognize that and we have to utilize that.
One benefit of it as well is you can take the best doctors in the world and the people who really know it better than anyone else. You can create scalable educational modules that you can then get out to many more people compared to a one-to-one relationship, right? So there's a way to not give up the magic of a great doctor-patient relationship, but find a way to scale that into the community in a way. More broadly on this topic, beyond the science that we can control what we do to some extent, there's also the broader political and legislative landscape. You've talked a little bit, publicly about your perspectives on the Educate Act, which has an impact on the kinds of things that are taught and ultimately what the doctors of the future learn in medical school. It'd be interesting to get your perspective on that because I know it's something that's important to you.
I am very concerned about these bans and the direction that our country is moving in terms of identifying, researching, and addressing racial health disparities and what those implications may be. Just to bring our listeners up to speed, so there was an act introduced by Congressman Greg Murphy in 2024 called the Embracing Anti-Discrimination, Unbiased Curricula, and Advancing Truth in Education Act, or the Educate Act. And essentially, it cuts federal funding for race-based mandates. So anything regarding education or training that relate to diversity, equity, and inclusion would be cut. And so, this is problematic, but I also want to point out that this is not the first. So there have been a number of race DEI bans. Utah implemented a bill prohibiting DEI in universities. Florida, Mississippi, Oklahoma, Tennessee, Texas, Iowa, they all passed bans kind of limiting education and training as it relates to diversity, equity, and inclusion. So this is problematic because this legislation jeopardizes the knowledge base, the empathy, the capacity of our future healthcare workforce to care for diverse communities. It's a crippling when we erase history. We are separating the role that history plays in the racial health disparities that we see today, and it is problematic. Humans have a habit of repeating things that they did previously. This is how we form behaviors. This is how we form habits. Even things that sometimes look new now or just things that we've done before, just wrapped
Yeah.
in new clothing. And so, you know, history is not just about learning something that's interesting and having a discussion at a dinner party. We learn about history so that we don't repeat it, so that we can do better, so that we can be better. When I was in medical school, I learned about J. Marion Sims actually from a podcast, which is why
Mm.
I love and appreciate what you're doing in your podcast. I learned about J. Marion Sims and the atrocities of the Black enslaved women, and then started reading on my own about the field of obstetrics and gynecology and the racist practices, the historical practices in obstetrics and gynecology. And I felt the need to do this because I was about to enter the field of OBGYN. I owed it to myself and my patients to
Yeah.
know about this. And then when I became an OBGYN and I'm seeing the statistics that Black women are 3 times more likely to die in pregnancy and childbirth. And I'm like, wait, what year is this? Oh, we're in 2024, 2025. What country is this? Oh, we're in America. These statistics are appalling and they're frightening. And there's a striking similarity to what we're seeing now in racial health disparities and what we saw 100 and 200 years ago. And so, as a response, I developed a curriculum at the University of Michigan at the medical school to essentially teach medical students about the history of OBGYN and how a lot of those historical practices, how they relate to the racial health disparities that we see today, namely Black maternal mortality. We published a paper on this called The Importance of Discussing the History of Racism in Medical Student Education. It's in the Journal of Clinical Obstetrics and Gynecology. And really, we polled students after this curriculum, and the majority of the feedback was really positive. Most of the students really, really enjoyed the course. And when we asked, do you feel like your participation in this course will lead to positive change in your own practice and future patient outcomes? 93% said yes. Some of the students even said that they're going to think more deeply about how they treat patients of color. This is exactly the type of introspection that we want in our future healthcare force. So, what can we do moving forward? We can protest, and protest doesn't always entail going out into the streets with signs. It in no way means violence. I don't condone that. There are a lot of ways to protest. You can protest with your pen. You can protest with your computer, with your voice, right? The things we choose to do, how we treat each other, how we spend our time, right? These are all ways that we can protest. We can write our legislators and make our voices heard that we disagree with some of these policies and bans, because these anti DEI efforts, they're stifling and they move us backwards. We also have a lot of information at our fingertips. So we owe it to ourselves to educate ourselves and empower ourselves. We can't always expect institutions that perpetuate racial health disparities to then teach us about racial health disparities, right? We have
Right.
to learn.
Yeah.
And we also have to translate what we know into action. If we know the data on Black mothers dying in pregnancy, for instance, then we're going to be much more vigilant about how we treat them, knowing that Black birthing people are at heightened risk. DEI programs create a backstop and a framework for this, but the absence of a DEI program should not stop us from providing exceptional care to communities that we know are underserved or disenfranchised. For researchers out there who are doing studies in genetics, if we know people of non-European ancestry are underrepresented in genetic studies, we don't have to wait for a DEI program to require us to include those communities in our research. We can and must do it ourselves.
Yeah, I really appreciate you bringing this up, and you're far from alone in registering your dissent with this particular bill. You're backed up by Association of American Medical Colleges and many others that I think are on the same page with you on this. So thank you for sharing it. More broadly, you're not only a researcher and professor, but also practicing gynecologist and obstetrician. Do you have any advice for people who are in the earlier stage of their career that might be interested in pursuing a career that goes in one or both of these directions?
Absolutely. This is actually probably the hardest question that you've asked me so far. Medicine is an incredibly demanding, challenging field. The first and foremost, the first piece of advice that I would give is be gritty. Dr. Angela Duckworth describes it as passion and perseverance for long-term goals. There are days where being a doctor is really, really hard, and this is where it matters, where you dig your feet in and you're gritty and your passion, your perseverance pay off. So that's the first thing. The second thing I would say is connect your interests and your talents to your life's work. Over
Mm.
time, I realize I'm someone who loves history. I love genealogy. I love understanding how humans interconnect genetically, socially, culturally. And thankfully, my work involves all of that. I'm very, very blessed to have a career that overlaps with all of my interests. And so I really encourage people who want to pursue a career in medicine to follow your passion and really think about areas where you shine and how that can come out in the type of medicine that you're practicing. Because when our interest overlaps with the work that we're doing to serve others, it gives it a boost. It basically superpowers what we do. Finally, compassion is really, really important. This is a topic that is not really popular these days, but compassion is, we have to intentionally wear compassion every single day. The same day a doctor walks into the hospital and puts on their white coat, we have to put on the clothing of compassion. It has to be an active verb, something that we're doing on a daily basis. It has to be integrated into how we breathe and how we think. And compassion is not just something that we are exhibiting in the doctor's office or in the operating room, but we're also showing it in the supermarket, in the lunch line, in when we're driving down the highway, right? This has to be a part of how we live. I really, really think those are all three really important things to think about in the career of medicine.
I love that. And this is advice that's not just good for early career people, not just good for medicine, but I think the advice you gave is good at any stage of your career and for all people. So I've taken a lot from that myself, not, and I'm sure many other people will too. So thank you for sharing that.
Absolutely. Thank you so much, Dr. Short.
Yeah, my pleasure. I heard from our producer team that you wanted to ask me a question too, which is great because I'm normally the one asking the questions, but it's nice to have the tables turned every once in a while. So would love to hear what you have in mind.
Yes, I want to ask you, how do you see genetics moving and evolving in the next 10 years? And what is your vision for the genetics podcast as we move into that new space, as we move into the new sphere of genomics?
Thank you. Great question. I love the question. So I'll start with the first part, the where I see genetics going in the next 10 years. I think there's two very broad pillars that I'm excited about. The first is gene therapies, gene editing, all of these transformative medicines that can take rare diseases that were death sentences for children and adults just a decade ago, and we've already seen dozens of them cured, And I think the best is ahead of us, right? So we have these incredible tools that can actually take previously untreatable diseases and make them treatable. That's primarily rare and ultra rare diseases, although it's starting to get into common disease. But that, I think we're just getting started on that trend. It's going to have bumps in the road, but I am going to continue to cover more and more experts in that field to understand where it's going. The other big area that I'm most excited about is almost the complete other end of the spectrum, the early screening, prediction, and prevention paradigm, which is a lot of what we talked about today. I'm interested in these population scale programs that you're talking about. I'm also really interested in newborn screening and how we can get what you're talking about is ending this generational disparity. Universal access to newborn screening to me is almost the ultimate end game of this. One of the unique things about genetics is you can test once and then you could turn over the genetic record to an 18-year-old and say, this is yours now and it's your choice what you do with it. And then they actually could have breast cancer screening at the appropriate time based on the whole genome long read sequencing that was done when they were a newborn, for example. And so I think we're getting to that world. It's going to take a long time, but I can imagine a world where if that's universally accessible, then every individual has the ability to use genetics, and it should in some ways almost fade into the background of medicine, which is maybe a good segue into where this podcast goes in the future. Because I think if we all do our jobs, then everyone should get genetically screened either in adulthood today, and then eventually as newborns, and we use that information alongside proteomics and the other new tools that are going to be developed in the coming years that will come to mean precision medicine. So I think, if we've all done our jobs in 10 years, we probably won't necessarily even think of genetics as precision medicine. We'll think it's part of the water, right? Every doctor knows it. Everyone talks about it. We use it to make decisions. But the new frontier is RNA or proteomics or some kind of new genetic testing and somatic level. So those are the two big areas I'm focused on. With the podcast, I like the name because it's simple, but longtime listeners will know that we've done lots of stuff that isn't genetics, lots of proteomics, lots of therapeutics development, other kinds of things. So I'm going to just continue to follow the things that I'm most interested, which is generally in those two big buckets. A lot of it is going to involve genetics, but it's always going to be sprinkled in with some of the new and exciting omics and other things that are on the horizon.
That's really great. And I'm very biased when I listen to your response because there's so much overlap that I see with obstetrics and gynecology. There's so much overlap in what you're talking about in prenatal screening and all of that. So that's really great. And I'm so happy and honored to be a part of this podcast for that reason. It's really exciting.
I really appreciate you coming on and sharing all the great work that you're doing. We'll definitely schedule a follow-up when you've got more exciting stuff to share. So thank you for spending the time with us today.
Absolutely. Please have me back on the show. I have so many exciting things to talk to you about that are in the pipeline for how we improve equity in genetics.
I would love to. And funders, philanthropists, anyone who wants to help Versha bring this vision to life, get in touch. You'll be able to find her. If you have the resources to help make this happen, then you'll know where to find her.
Pleasant.com.
Yes, perfect. All right. And thanks everybody for listening. We will see you next time. That wraps up this week's episode of the Genetics Podcast. I'd like to give a huge thank you to our guests for sharing their valuable insights and experience. And thank you as well to our listeners, as always, for tuning in. If you enjoyed today's talk, the number one thing I would really appreciate from you is if you could share it with a friend or colleague who you think would enjoy it as well. We would also really appreciate if you could subscribe to our show and give us a quick rate and review on Apple Podcasts, Spotify, or your favorite podcast platform. Both of these things help us become more visible when people search for genetics and precision medicine podcasts. And we're always eager to hear from you. Please reach out to us with any questions or feedback on social media. You can find Cynogenetics on Twitter, LinkedIn, or visit cynogenetics.com. Finally, a big thank you to the team behind the scenes who make all this possible. In particular, Amy Cousins and Sonia Shah, who produced the show, and James Pierce from Selected Frequencies, who handles the audio engineering. I'm Patrick Short, your host, and it's been a pleasure. Thank you, and we'll see you next time on the Genetics Podcast.